Hello, I am Dr. Livaditis, a practicing prosthodontist in Baltimore, Maryland, and the developer of the matrix impression technique, along with several other restorative procedures. The MIT has been successfully used in my practice for over 30 years. There is a moderate learning curve to implementing the system. It includes best features of other impression systems, but challenges some existing concepts and procedures. And I believe it's the best system for teaching crown and bridge impressions. There are three categories or approaches to crown impressions: the copper tube impression family, the wash reline group, and the syringe tray approach. MIT will compare and contrast features with the syringe tray group, which is the most common conventional impression technique. MIT is not competing with scanned and computer-generated casts. Even for offices routinely scanning, MIT is the best backup method when scanning is not applicable or available. Let's talk about finish lines and crown restoration margins. MIT has little value for impressions of implants only. MIT is valuable with combined tooth preparations and implants. The value of MIT for impressions of crowns or inlays varies. There's little value for supragingival margins. It's valuable for equigingival margins, and it's very valuable for subgingival margins. It's extremely valuable in deep margins resulting from severe wear, fractures, or caries. And also MIT eliminates the need for dual cord retraction, often applied during scanning of teeth. These images illustrate the matrix system. The concept of custom tray is converted from arch level to tooth level. The matrix displaces the gingiva, and the matrix typically extends into the sulcus, but the matrix itself does not record the finish line. It cleanses the sulcus at the critical moment, which is valuable, and it keeps the gingiva displaced during the seating of the tray, also valuable. And the material is delivered to all abutments in the matrix simultaneously. Using a shell used to form a temporary crown serves to demonstrate an important consideration. On the left, the shell extends beyond the crown margin onto the ridge, similar to inserting an impression tray filled with impression material. Now, some material may flow into the sulcus, but the overextension may limit or serve to collapse the gingiva, preventing material into the sulcus. In the middle, trimming the same shell back to the crest of the gingiva allows or even directs the resin material into the sulcus. Note the U-turn change in direction of the material. Now, one may say that change in direction may result from the impression material colliding with the crest of the gingiva, and that may be true. But the impression material has a much greater chance of being diverted into the sulcus. The clear shell extends to the crest of the gingiva, but not into the sulcus. On the right, the matrix is created and trimmed to some degree within the sulcus, effectively directing impression material into the sulcus and trapping the material in the sulcus. There are 2 times to form the matrix and 2 times not to form the matrix. Immediately after crown preparation of teeth is the best time. That slight space between finish line and gingiva is best picked up in the matrix at this time. After removal of the interim crowns is the second best time for similar reasons. The 2 unfavorable times include after loss of the interim crown and healing of the gingiva against the prepared tooth margin. Now, you may consider making the matrix when the gingiva is retracted would be a better time. Not so. Since the matrix is made with retracted gingiva, when the cord is removed, the stretched gingiva may begin to collapse and the matrix may actually cause collapse of the gingiva in certain areas. There are 4 types of forces impacting the gingiva during crown impressions and affecting the successful registration of crown finish lines. Retraction is actually a pre-impression step, accomplished by placement of the cord, gingival retraction by chemicals, resection of the gingiva, or insertion of collars or tubes in the sulcus, such as the copper tube system. Relapsing is the immediate return of the gingiva to the original form and position caused by removal of retraction cord or rebound of stretched gingiva. Collapsing forces includes procedures that cause the gingiva to move toward or against the tooth surface, such as tray and material flowing over the gingiva once cord is removed, also caused by higher viscosity of tray material over sulcus material. Displacing, pushing of the gingiva away from the tooth by the impression, enabled by forced delivery of sulcus impression material, higher viscosity, sulcus material, and unrestrained gingiva. There are 2 forms of displaced forces, temporary or durable. Temporary is when material can be squeezed out of the sulcus during follow-up steps. The durable is when the material is trapped to the sulcus or allowed to set before the tray material is delivered. Another feature to be discussed is hemostasis versus hemo-displacement. No impression technique removes dried blood on abutment teeth. Now, hemostasis can be accomplished with local vasoconstriction, retraction cords with hemostatic agents, and thermal coagulation of soft tissue and small blood vessels. On the other hand, hemo-displacement can cleanse the sulcus at the critical moment and maintain the sulcus blood-free by the matrix trapping the impression material, preventing further bleeding against the tooth surface. Let's talk about the viscosity of impression material. The current system is light body for syringing or sulcular component, or medium body for tray material. The proposed system is medium body for sulcular component and medium body for tray material, or preferably heavier body for sulcular material than the tray material. Let's talk about adherence of impression materials. First of all, considerable stress can occur at the interface of 2 materials and between tooth surface and impression material. With MIT, there is tooth reline interface, reline matrix interface, and matrix tray interface. All current sulcular and tray materials adhere well when both set or polymerize concurrently. Not all sulcular and tray materials adhere well when setting separately. Delamination may occur, especially when the stresses are very strong. BPS or PVS materials do not adhere well if setting separately. Therefore, adhesive on the matrix is needed. Polyether materials adhere well even if setting separately. Surface contaminants may affect adherence of both materials. Quite often, you fabricate the matrix in the laboratory and you have to disinfect it to take it into the operatory. And commercial disinfectants may serve as surface contaminants. They may act as a lubricant on the matrix, or they may leave a remaining film on the matrix, affecting the bonding of impression materials. I suggest you use alcohol around 90% concentration for disinfecting the matrix instead of commercial materials. Let us illustrate the impression phase and then return to discuss the design of the matrix. The matrix impression sequence begins with step 1. The finished matrix is inserted and a tray is selected, and tray adhesive is applied. Step 2. The single retraction cord is inserted, and you may consider using glycerin to prevent delamination when removing the impression. I don't typically use it, but if I had very long preparations and adjacent preparations where I expect a lot of stress in removing the impression, I may apply glycerin, and then the excess glycerin would be dislodged by seating the matrix. Step 3, use a syringe to fill the matrix with tray viscosity impression material. A syringe is used to avoid trapping air in the matrix. Apply impression material to all matrix teeth and edentulous areas of the matrix. The retraction cord is removed by the assistant while the matrix is being filled. Any excess material is applied around the teeth for flushing the sulcus. It does not have to be directed into the sulcus. That's the job of the matrix. And this is not typically applied unless impressing very small teeth like lower anterior teeth or short abutment teeth, which have minimal material in the matrix for flushing. Step 6, insert the filled matrix with moderate pressure. You have adequate vertical stops to prevent overseating of the matrix. Step 7, while the matrix filled material is not set, the tray with tray viscosity material is seated. And step 8, you evaluate the impression for registration of finish lines, sulcular integrity, and lack of blood contamination, and you'll be very impressed in all 3 areas. Now let's look at bilateral impressions. Mark the facial surfaces for proper matrix orientation. When filled with material, orientation of the matrix is basically lost. Mark left or right for proper matrix positioning in the mouth. Step 2, fill and seat the first matrix. Wipe excess material with your finger. Allow material to set. Note that the matrices, because they are VPS material, are covered with adhesive before beginning. Note the excess material on adjacent teeth, attached or mobile. Do not be concerned. Tray material will pick up the material as part of the overall impression. Step 3. With the first matrix completely set, fill and seat the left matrix. The second matrix need not set. Insert the filled tray within the working time of the second matrix material. Or you may wipe excess and allow the second matrix to set completely before inserting the tray. Bilateral impressions are simplified, especially for isolating the 2 sides as virtually separate impressions. Managing short and isolated abutments. Extend the matrix 1 centimeter on alveolar ridge as additional vertical stop. Extend the matrix 5 millimeters on facial and palatal of the ridge to prevent rotation of the matrix. Option 1, you insert the matrix and tray materials together. Or option 2, wipe excess reline material and allow it to set. Use a filled tray to pick up the preset relined matrix. Segmental impressions. Step 1. The matrix may be 1 or more segments. Matrix segments may be made at different visits because you may be doing the preparations on different visits, and the matrix is best made during that visit. The single long matrix may also be cut into segments, but allow space between segments. And I don't mean the space that would allow dental floss to pass through. you need to have enough space that you can clear that space free of impression material to allow insertion of follow-up segments. The best segmentation is over edentulous sites. Step 2. Seat 1 or even 2 segments with relined material. Wipe and clear excess material for one or both segments at the same time. Clear the space between segments to allow seating of the final segment. Use 2x2 gauze sponges for that purpose. And allow material to fully set for the first 1 or 2 segments. Step 3, seat the final matrix with a new mix of relined material. And seat the tray with tray material immediately. And allow both materials to fully set. Step 4, evaluate the impression. The tray picks up all segments and additional teeth. Segmental approach simplifies complex impressions. Observe the durable sulcular extensions. Triangular in shape, a narrow portion is in the deepest part of the sulcus. Now let's take a look at a couple of impressions that exhibit some blood in the impression. The blood is displaced away from the sulcus. Cleansing occurs at that critical moment of seating the matrix. Now, if you look at the impression, some blood may be drawn into the impression upon removal of the impression. But when you rinse the impression out, you'll see the abutment surface is contamination-free. Now let's go on and talk about the forming of the matrix. And you have 2 options, direct and indirect. You want to extend the matrix either way, 1 intact tooth on each side when possible. And include pontic areas within the matrix when there are no adjacent teeth. Extend 1 centimeter onto adjacent and edentulous areas. Use high viscosity impression material or semi-elastic occlusal registration material for the matrix. In forming the matrix, the direct method is preferred. It results in a better matrix. The indirect allows laboratory support in the fabrication. The direct enables same visit for crown prep and impression. The indirect favors separate impression visit because you have to create the hydrocolloid impression and the cast, and you may want to send it to the laboratory. If you are just trying out the MIT system once or twice, you may use a stock tray to carry material to the mouth to form the matrix. However, if you're using the MIT system on a regular basis, you will want to make some shells, pre-made shells to carry the matrix. It will conserve impression material. You can reduce trimming time by reducing excess material. It enables improved positioning of the matrix and improved visibility. And it's easy to do. You just take a couple of models, fill in the abrasures, put a layer of wax over the teeth, duplicate the models in stone, and use a vacuum pressing instrument to create plastic shells. In refining the matrix, step 1 is you want to rough trim the matrix close to the gingival crest and retain 1/2 tooth on each side, and you can do that with the scissors or a scalpel. Step 2, you use a burr or abrasive stone to trim very close to the gingival crest, and you want to do it at a 45-degree angle to maintain the thickness of the matrix. You don't want a thin flange extending into the sulcus. Step 3, trim or relieve the proximal wall of intact adjacent teeth. And you want to just create some space on the intact teeth for impression material. You do not trim the internal occlusal surface. That's another valuable vertical stop. Step 4, you enlarge or trim open the interproximal areas. Now, this is a really nice, valuable feature. The matrix positions the interproximal tissue precisely between the two prepared teeth. Now, you may think that, in seating the matrix, that you may be very close to the one tooth and have excess space on the adjacent tooth. That doesn't happen. The matrix, because of the numerous teeth involved, is precisely positioned over the abutment teeth, and that's one of the features. Step 5, trim internal axial walls of the abutments. You might ask, how much do I trim it? Well, the best way I can describe it is about the thickness of a piece of paper. Or if you were to put a pencil mark on the inside of the abutment and you trim that pencil mark away, that's sufficient trimming. Now, bear in mind that in the end, you may see the matrix through the impression. There's nothing wrong with that. The matrix becomes part of the impression. Step 6, do not trim internal occlusal or incisal areas. They are also valuable vertical stops, preventing distortion of the impression and ultimate form of the crowns. Step 7, add landmark for positioning the matrix in the mouth and also whether they are facial or lingual. Step 8, note the relation of the matrix to the gingival crest and sulcus. Select a tray to allow for the matrix and the remaining teeth. Now, potential errors leading to impression failures. Delamination. Use adhesive on matrices made with VPS or PVS material, as you may refer to them. Fill the matrix with syringe to avoid air bubbles. Matrix malposition. Failure to indicate a reference, buccolingual in position in the mouth. Tight crowns. The matrix is overseated due to trimmed vertical stops. Failure to try in multiple matrix segments for separation purposes. Failure to relieve axial walls and adjacent contact areas. I don't think that's going to occur. That's a basic component of finishing, finalizing the matrix. Now, failure to select a tray to allow space for the matrix could be an oversight. Now, a review of the refining the matrix or checklist. Include 1/2 intact tooth on each side. Create space between multiple matrix segments. Enough space to be able to clean the area. Trim facial and lingual outer surfaces to gingival crest. Trim proximal contact areas of intact teeth. Trim and enlarge interproximal embrasures. Trim the internal axial walls of the prepared teeth, but maintain vertical stops. Do not trim internal occlusal and incisal surfaces. And apply adhesive to VPS matrices.